Okay, the case number 2, as you can see, is a 66-year-old male. Patient has angina symptoms and had a bypass, Lima to LAD, which is good. EF has been 30 to 35, end-stage renal disease, has a BKA, peripheral arterial disease, and on a reasonable medical therapy. And basically what happened is, patient had a cath few days ago, and this is the finding. Patient had a stent, the Ramus ever had stent or just occlusion?
Just occlusion.
Yeah. See the CTO, very little diet deficiency on the left side.
Yes.
LAD proximal subtotal, mid LAD, Lima is fantastic, fills entire. Then there is a large OM or ramus, totally occluded, calcific. Circ itself is a small artery, but the money is here. LV dysfunction, EF to me actually not even 35, to me it looks like 20, 25. And now EDP was 26. And I know there was a discussion about EDP. I can just tell you that in a part of the, as a one of the investigator, and I know Amir Kaki is there, as in executive committee, and so always the issue was that do you make a criteria of a EDP when you are doing the Protect 4 randomization? And I can tell you consensus was it has to be LV dysfunction, complex CAD, LV dysfunction, EDP does not matter. I just want to say, although we believe if patient is well compensated, maybe a different story versus who is uncompensated. But just to say, randomized trial ongoing at present has no role of LV-EDP. Within the trial format, there are patients who will have a right heart cath. So center has to designate right heart cath. There we go, all the hemodynamics and so, and we elected not to be. Right now, as you know, the trial is about 400 plus, and we are like 46, 40, 45 plus, 46. 10% of the trial patients had been done from Mount Sinai. So just to say EDP is important for discussion, but in the actual trial format has not been the part of randomization. Do you do put a Impella or not? So with that note, because this patient actually is a hemodialysis patient, was dialyzed yesterday, but still EDP was 26. So with that EF, so we felt that we do a CP, and if you can see the camera, same, that allows up to 6 to 7 French sheath through the same hole. So that is the key, single puncture, and you just do outside. You don't put in the Impella one diaphragm, you have to do a separate puncture and then put a sheath in, 7 French, and then you can do just 6 or 7 French guide. One limitation of this technique, single access. If you have to do too much manipulation of the guide, very tough. It's a straightforward, yes, but if you need too much manipulation of the guide, not good, maybe better to go puncture other side. Because very, very difficult. We have seen it. Even you put a long 7 French sheath all the way to the mid aorta, we have it. So basically, this case was done because of this. Look at the calcium. I won't even call it tramp track. It's like entire vessel.
Yeah.
The whole vessel, and particularly, as you know, that severe calcium because of the hemodialysis. And this was the lesion, proximal and very calcific lesion in the mid RCA, right
almost
there.
Looks like
big.
Almost like a nodule.
So we said,
at that site.
Almost like a nodule. Yeah.
So I don't know. We'll have to see. I don't know if you imaged it.
Good. All right. Let's see. We did the imaging. All right. Let's see
Dr.
the imaging
Sharma,
guru. Show the OCT, please.
Okay, sure. So this is the distal to the nodule part.
Large vessel, 4.5 plus. Yeah. Yes. Okay, show us the nodule now.
Yeah, now see the irregular surface and the attenuation. This is all the calcified nodule, eruptive calcified nodule.
No, it isn't.
And also the part has a specific calcium, like combination of nodule.
So this is the case will be 360-degree calcium with added nodule, big nodule there. So question was, and there is a lot of data that nodule may do better with the shaving, either orbital or rotational, and then may still can use, you can still use the IVL. We actually have the two case report, one with the IVL, one with the rotational atherectomy with the IVUS and OCT, and we call it a shaking or shaving. So basically you can do shake it by IVL and it will still do okay with the nodule, or you shave it by the orbital or rotational atherectomy. So what we have done here is, and then this patient also has a look at the distal lesion at the AV continuation. PDA is 2 PDA. One PDA is kind of closed. We said we had to take care of that also. So this is a rotablation of 1.75 bar. And I just say at this time, irrespective of the vessel size, to use, we are the highest probably rotational atherectomy user in the world, doing about 500 plus every year. So to burr more than 1.75 or maybe 2.0 is almost disappear. Of the 500, maybe we'll do 1 or 2. As you have spoken about the device synergy with the rotor shock. This is a 1.75 second lesion, a little tough. And the third lesion, which is the AV continuation, here was tough. I've seen this now. And this is what the other teaching point we are making. See, I tried about 5 runs, and you see it goes to the half lesion. Don't push. The concept of half or 3/4 atherectomy. You don't have to go all through. You have created the plaque, which was also very calcific. You have created the crack in the plaque, and now your balloon will do the needful. And we bring the balloon,
but is
and
it
you can see balloon opens up very nicely.
IVL balloon or a regular balloon?
And then we put a stent there.
But why not come with an IVL balloon when you didn't really fully?
No.
Well, tell me what the concept is there. Why not?
Concept is because long angulated rotablation, biggest problem happens when you're ready to come out and there is a lot of resistance. So you have perforation or dissection.
No, I get that.
So key is you try 4 or 5 times. And I have shown it now, at least in the live cases, more than a dozen times. The long lesion, you want to do it. But you did everything for good. You're 5.6, accelerate, you change your speed from 160 to maybe 180, and it still doesn't go. That's fine. Do not need to undersize the burr. As long as you're engaged in the lesion, you have done at least half of the burring of the lesion, because now you have created a crack in the plaque and your balloon will do the good. Now this is the 3020, the stent, the synergy stent has been placed, and now we are ready for the main show. That let's see what the rotablation has done to that mid RCA. You see RCA is still now shaved, clearly looks better than what it was before. But more importantly, truth is in the pudding. We are doing the OCT. Now, this is a lot of people change the OCT. They try to use the small injector, which is okay. But I have another technique that even you can do sometime if need to be. Put the guide liner or Guidezilla, and then just you'll be able to inject a small amount of dye, or sometimes even with a saline. You can see a patient with a high creatinine. In this case, is not the issue because of the renal failure. So now we are ready to see the follow-up OCT after 1.75 burr to see what it has done.
So while you do that, we have some comments on the table here. I want to make sure everybody's hearing, and then we'll go to your OCT. Jazz?
Yeah, I think Dr. Sharma's point about engaging the lesion distally and not pushing is important. You know what Rota does? You know, in hourglass stents, Rota used to work. You know why?
That's feeling
not because
the
it was
great
cutting
picture.
metal. It creates so much heat and the pulse that it creates. So when you engage the lesion distally, you create so much heat and the pulse, which is similar to shockwave actually, then it breaks those calcium. And I think that's why he's shown in several cases that those lesions actually healed after that. So that's one very good point. And the other thing on OCT, this is a very complex nodule, and these have very high TLR. These are eruptive nodules. So the way you described, I'm sure they'll go back and show these are eruptive nodules, and they have higher TLR over time. So you really want to do a good job with luminal gain in this scenario.
Yeah. So I guess what I wanted to hear, I wish I had seen a little bit something other than rotablator here. Arthur?
With eruptive nodules tend to have more microcalcifications in the cap, right, which makes them a little bit easier to yield than sort of that if there's dense calcium that's buried deep into the nodule.
Yeah, Dr. Sharma, sorry, we haven't seen any. We're talking here. I don't know if you're here. You heard us. We asked for a little break so we can have the table also comment. Okay, can you go back and start from the beginning of the OCT run, please?
Sure, Dr. Milan. So actually, this is not a perfect image because still some residual blood. But we saw the tightest part, the nodular part, and you see the 3 o'clock. You see the shape, the surface of the nodular calcification. So at least a lot of work. But this patient has the other part also has a suicidal calcium, but we cannot see the fracture at the calcium seed part. So just we saw the shape, the surface of the nodule parts.
The question is, and I think we need an opinion from all our experts on there who are imaging expert also, that has Rota shaved that nodule? That's the question we have.
I mean, in my mind,
can I ask a question? If on OCT you're seeing fractures in multiple areas, if there are 3 fractures or more that are seen by OCT, does that give you then permission to move forward with stenting at that point? Is that the criteria at which point we might say, okay, let's go ahead and implant?
I'm not so convinced that the rotablator did much of anything to that nodule. I don't know. I want to know what others think.
Tell us.
Yeah.
I think
Amir.
At the area of the nodule, has it shaved a little bit?
Yeah, actually, this is shaved. This is shaved.
What was the depth before of the nodule and what is the depth of the nodule now?
Tightest MLD was 1.2.
And
this is the shaved part is 2.3.
Okay, so it looks like that exactly for the size, about 1.6, 1.5 plus, the length. I mean, lumen has increased there, Roxana. So it has shaved the nodule. Okay. Maybe you can show the previous nodule. Can we show the previous one?
As you do that, Amir Kaki has a comment. Amir?
I just think in general, when we're treating these very calcified, complex lesions, when you're doing plaque modification, I don't think it's appropriate to do your plaque modification then follow with the stent. What's most appropriate so that you could avoid the stent regret is take a 1-to-1 NC balloon if it fully expands, and then the vessel is prepped.
But we have imaging, and let's use it. Let's not just eyeball everything.
Look at the nodule before.
But even with the imaging,
this was pre. Are you seeing it?
Yeah.
Look at how big nodule with a 1.2 lumen. Now it's a 2.3. So definitely did a good job. But now question is, and that's a very good question by Reitman, that what are the criteria we stop? So remember, OCT has, your stent is expanded, the red dots comes, disappear means the stent is good, red dots there means you need to expand more. We still need a calcific AI algorithm that we have done this. Now you can go with the balloon and your stent rather than you do additional plaque modification.
Amir thinks you could just put the balloon there. Amir thinks just put the balloon, see if it dilates. But I'm also concerned still about that proximal lesion to the nodule. We didn't even see that. Did that get nicely cracked, and is that going to be okay?
No. Yeah, that lesion, actually, we did not do much to the lesion. But just to say, having said not knowing that you need to do, we are doing a 4-0 IVL into both those lesions now.
Okay. What is everybody saying?
So now question is,
I will definitely
it's a
do
4-0.
IVL, because when you have a nodule, a high pressure balloon may look well expanded, but it's not.
It may not be.
I don't believe the high pressure balloon is the answer to lesion preparation when you have a nodule.
Well, let's hear from Kate. Kate, what would you do? Next, would you go with an IVL after that just short rotor run?
I think in some of these cases where you see the nodule there, it does make sense. Prior to IVL, we were using a lot of modified balloons. So I think for me, the struggle is when is that enough? Because you do have some cost savings there. And when do you need IVL? I think here usually I'll do a fair bit of ballooning before that repeat imaging run just to help decide if we need to pull the trigger.
Okay, good.
Go to
All right,
6.
Dr.
So this one we are going to 6 atmosphere, and run. This is the third run. Now this is the first time to the proximal lesion. Just to come back to it, Roxana, my 1.75 bar.
I have our keynote speaker waiting very patiently for all of you being delayed. We're 10 minutes behind time, so let's show us what's next.
And we'll be done in 2 minutes now. Go one more.
Okay, I'm glad I have some.
So.
Dr. Sabatine is here and ready to go. So let's get this show on the road.
We are all waiting to hear that.
Yes. Yes, Dr. O'Neill.
Some of us are old enough to remember doing these nodules with just balloon and stent, and you have a huge risk of rupture. So I think you can't do this without some modification. It's really dangerous to do that.
Very, very good point. We've seen that now. 4.5. People who are not modifying. And now there is an option that if you're uncomfortable with rotablator, you can use IVL and should at the very least. And that probably would work just as well or not as well. Jazz, you think that would work? Did we need rotablator here?
No, I don't think so. It's a large vessel, and if you can take a guide extender and get there close to the balloon and do IVL, I think you probably do as decent of a job. Distal, probably not. With the tortuosity,
so if you're going to do it distal, you might as well go to it. Okay, did you hear that, Dr. Sharma? I was questioning whether we even needed rotoblader here, and Jazz says for sure for the distal, but
no, I would say no, but I can tell you having that. If it was only circular calcium, I fully agree with the Jazz with this. This is not a circular calcium alone. With the circular calcium followed by 2.5 millimeter of the nodule.
Okay, well,
so this one just because of that. Combining, but anyway, now we are ready. We have done the already there, and we are ready to put a step. So let me show you here, and then as we talked about that OM, since we have done the Impella, we'll open the OM also. That will do off screen. We don't have to worry about. But let's see where the money is. This is the complex rota shock, rotablation with IVL, and of course with the imaging guided multi-lesion right coronary. Okay, let me show this now.
Oh,
all
really,
right.
really nice. Beautiful results.